right, so this one isn't quite as exciting as the other ones were, but you know, as rehab goes, I don't know if what you guys think, but we've kind of changed our protocols over time, and then try to make it more towards the patient. But in our practice, you know, with our own therapy and with the Advantage home therapy that we use, you know, we kind of go based upon what they use, and they kind of, you know, they know more about rehab than we do, so we kind of let them take charge of it. But the most important aspect we have found is the pre-education of the patient. You know, what's going to take place, what's going to be most useful for you in your post-op recovery. You know, knee rehab is vital to post-op success. I would say to add to some of the things of a patient you don't want to operate on is the patient says, I don't want any therapy afterwards. I mean, that's another patient that might be a non-candidate for surgery. But pain management is also important, because if they have terrible pain, they cannot tolerate the therapy, but sometimes the therapy is just too much for certain individuals. So there's 3 phases that our group's divided into, you know, surgery to 2 weeks, 3 to 6 weeks, and 6 to 12 weeks. Phase 1 goal is obviously just safe transfers and ambulate with assistive device. You know, we don't need this patient to be bent to 155 degrees. I ask every patient in the office, all right, how much is your range of motion? And they show me. So, well, you know, we all know that the biggest predictor of post-op range of motion, how good it is to start with. So if they're at 110 and they like their knee, they don't need to get to 140. If they're coming to my office at 3 weeks and they're 115, 120, and they're feeling good, stop therapy. I don't think it's really necessary. That's kind of why we can get away with doing a little bit less therapy for some of these people. You know, literature supports range of motion return to your pre-op level. You know, obviously there's the pre-op flexion contractures, which that needs to be spoken with the patient, what's going to take place and how we're going to fix that. And we try to encourage every patient to at least get back their pre-op range of motion. But we do tell them you're probably going to get more than what you got now, but it's important to set that expectation ahead of time. You know, an age activity should help guide your rehab. You know, the 85-year-old lady doesn't need the same rehab as the 40-year-old guy. So some of these physical therapy places, they want to, you know, a lady comes in, she's in pain, they're just pushing on my leg so much, and I ask them, well, how are you doing otherwise? Can you go to the store and get in your car and do your things? Oh, yeah, otherwise I'm doing fine. Stop therapy, you're done. You don't need to do any more, you're good to go. So it's kind of what we do in our own practice. The exercises, you know, simple quad sets, straight leg raises, prone hamstring, sit to stand squats, stationary bike with no resistance. I think it's a wonderful exercise in the beginning. You know, lots of ice, E-stem, TENS units. And we try to do that hurt versus harm education. You know, they're yes, the physical terrorists, as we call them, they're helping you, but they want them to harm you at the same time either. So the phase 2 goals, again, 0 to 125, I think is a great target. Quad strength, again, without lag and the straight leg raise and the short arc quads, and the progression of strength towards their body weight, and trying to equalize their weight bearing on each leg. The phase 2, you know, this is manual therapy. A lot of therapists don't like to touch their patients, so we make sure we have therapists who actually lay their hands upon the patient, as opposed to having their hands laid upon a newspaper all day. So we want that therapist to touch our patient so that psychologically they're getting some work done, and also it helps with therapy in itself. The neuromobilization of a tibial nerve can help with flexion contracture. I did not know that until I met with our therapist, and they kind of told us this. It's a kind of interesting thing that they try to do. Normal quad sets, leg presses, you know, and lunge throughs with partial range if safe. You know, I don't need the 83-year-old lady to be doing, you know, lunges and things like that, but you hear that they do that sometimes. I think it's just unnecessary. Standing total knee extension with TheraBands, and the pull is a wonderful exercise for a lot of people, if needed, if the wound's healed. Phase 3 goals, again, 0 to 125. That's kind of what our mantra is. You know, you don't need to go beyond that. If it goes beyond that, that's wonderful. But by this point in time, should be no extensor lag, normal gait, and stairs with a reciprocal gait. But as we all know, no one likes to talk to a patient about stairs because it's the one thing they always complain about. So we usually don't bring it up too often in our office. Phase 3, lateral and multidirectional movements, quads and hip core strengthening. And if flexion contracture persists, we continue with ultrasound for tissue extensibility and increase prior to stretching. What that means essentially, try something to soften up those hamstrings in the posterior capsule before we actually start to, you know, lay on the knee to get it to go straight. And again, stationary bike for range of motion and stiffness. For the hip rehab, you guys all know hips are much easier to rehab, you know, without question, a lot much easier to do. And we just have simple routines of core and hip strengthening around the abductors and flexors, walk and eliminate devices when limp is minimal. And we have no restrictions. We're, you know, I'm a posterior approach guy. Ken's lateral. Most of the other guys are posterior approach. We have no restrictions. We let them do what they want, bend, twist, turn, no pillows. So we kind of let them have at it right away. But overall, the rehab, this is kind of what our therapists do. They don't do too much more than these exercises. And again, total joint rehab in general, works better with pre-education. You can tell them what to expect. We tell them that your therapist is going to move your knee. We don't want them killing you, but please tell us if they are. Maybe to modify your medications. Please call us and let us know those kind of things, because a lot of patients are afraid to call in. You got the patients who love to call in for meds, and there's a whole bunch of people who don't want to call in for more medication if necessary. So we have them make sure they follow the rehab protocols that we have instituted or our therapists have instituted. And remember your patient. Try to individualize it somewhat depending on their age and their preoperative goals that you've talked to them with ahead of time. Thank you.